Friends, welcome to my workplace for hands-on Phaco and SICS training. This is an intumescent cataract. Let us observe this surgery. This is the main incision with a 2.8 mm steel keratome on the posterior aspect of the limbus. And now a side port is made on the left side of the main incision about 3 clock hours away. An air bubble is injected into the anterior chamber. Underneath this air bubble, trypan blue dye is applied over the anterior capsule. Care is taken so that the dye touches all parts of the anterior capsule. Few drops of adrenaline, and then the dye is washed out using a Simcoe cannula. And now 2% hydroxypropyl methyl cellulose is injected into the anterior chamber. The anterior chamber is filled up with this Visco, and now capsulorhexis. Utrata forceps is taken. A capsular tag is raised, and immediately this capsular tag is held and guided anticlockwise to get an small rhexis, a mini rhexis. Size of this rhexis is about 2.5 or 3 millimeter. And now some cortical matter is aspirated. Not only the cortex from the anterior part, the cortex from the posterior part also is aspirated. Go through the side port, aspirate the cortex from the subincisional area, and now the nucleus is gently tapped. And as we do this, the cortex from posterior part starts coming out anteriorly. And then the nucleus is rotated, and the nucleus is tapped. As we do this, some more cortex from posterior part comes along the equator anteriorly. And as we remove these cortical matter, the intralenticular pressure is greatly reduced. And now Visco again to fill up the anterior chamber. Now I take a 1/8 scissor, make a nick, take the Macpherson's forceps. Now take the utrata forceps and enlarge the mini rhexis into an optimum sized rhexis. Size of this rhexis is about 5.5 millimeter, and we find a hard nucleus. So white cataracts may have very soft nucleus of moderate density, and this kind of hard nucleus can also be there. Whenever there is a hard nucleus, I employ my technique submarine job. See the exposed part of the tip. It is little more than the other cases. The nucleus is pushed little down, the tip goes through the substance of the nucleus towards the opposite equator. And now the nucleus gets divided into, we get a nice crack, still not divided into two heminuclei. Rotate 180 degree, come to the other side, and the two halves are completely separated. And now this heminucleus is chopped again into 3 parts. come to the other heminucleus. This heminucleus is chopped into two parts. All the nuclear pieces, no, not all the pieces are free. These three nuclear pieces are free. The free nuclear pieces are emulsified. Now let me tell you the settings. From the very beginning, the ultrasonic energy is in continuous mode and set at 80%. Flow rate is, aspiration flow rate is 45 ml per minute. Vacuum is 450 millimeter of mercury. And now the pieces are emulsified. Care is taken to emulsify the pieces, bring the pieces to the central part. Now see this, separating these two pieces in this way. Tilt, and at the point where the two pieces are joined to each other, ultrasonic energy is applied and the two pieces get free. And then the pieces are emulsified. Though the ultrasonic energy is in continuous mode, the ultrasound is used very judiciously. Whenever the ultrasound is required, only then the foot pedal is pressed to get the ultrasonic energy. And during emulsification of the last piece, the vacuum and flow rate is reduced. Vacuum is 300, flow rate is 30. And we are done. We have managed the nucleus. Some Visco to protect the corneal endothelium. And now I am using this Simcoe cannula to remove the cortex. The Simcoe cannula is attached to a separate bottle. So as I hand over the handpiece, immediately I get the Simcoe. So there is no time gap. This not a second is lost. And we have only one side port. The width of this side port is 1.8 millimeter. If we had two side ports, it would have been 1.2 plus 1.2, that is 2.4 millimeter. The side port is 190 degree away from the main wound, so some amount of astigmatism induced by the main wound is neutralized by the side port. Now this is a hydrophobic acrylic single piece monofocal aspheric intraocular lens. The lens goes into the capsular bag. The lens has been implanted with Visco, so we have to remove the Visco thoroughly. 3 steps. Step 1 is to reduce the amount of Visco by the Simcoe cannula. First I irrigate for some time. Irrigate through the aspirating port also, taking some Visco in the syringe, taking some VSS in the syringe. Go behind the intraocular lens, flush the space between the lens and the posterior capsule, and about 70% maybe Visco is aspirated by the Simcoe. And now I take the bimanual irrigation aspiration. This is step 2. Irrigate the anterior chamber, irrigate the space between the lens and the posterior capsule, that is the capsular bag is also irrigated. And now irrigate and aspirate for some time the anterior chamber. All the Visco from the angle and anterior chamber is reduced. So this is step 2. And now I inject some moxie and close the side port. Hydrate the side port this much. The main wound has been constructed a triplanar incision and it will not require any hydration for sealing. This is step 3, final lavage. At this time, the antechamber is lavaged thoroughly, the antechamber is formed nicely, and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.